Now, I want to ask you about the COMBI-V study because you've been combining MEK inhibition with RAF inhibition, and you're getting quite an interesting result. Now, tell me, what is the study? What were you trying to do?
So this is a phase 3 study. And the main goal of this study is to demonstrate an overall survival benefit of the combination of anti-BRAF Dabrafenib plus anti-MEK trametinib versus anti-BRAF vemurafenib.
Now, these specifically were patients with melanoma who were positive for BRAF.
Exactly, who have a BRAF mutation. It can be BRAF V600E for 90% of them, or V600K for 10% of the patients. And this is a first-line treatment. Patients have not been treated previously for their metastatic melanoma.
Right. Now, you had the combination arm and the single-agent arm. What did you find?
So we found that the survival was increased with the combination with an hazard ratio of 0.69. That translates into a reduction of the risk of dying of 31% with the combination compared with the Dabrafenib.
What were the toxicities when you were using both MEK inhibition and RAF inhibition?
So surprisingly enough, the toxicity is not increased by combining two drugs. And actually, if you look at the grade 3, it's a little bit decreased. We have around 48 versus 50 something with the single agents. But if we look in detail into the adverse event, the spectrum is slightly different. Some adverse events are more frequent with the combination, like pyrexia, chills and vomiting, and some other adverse events are decreased by the combination, and mostly skin adverse events. And interestingly, among the skin adverse events, we have the skin proliferation, because we know that BRAF inhibitor can favor the emergence of some skin cancers that are less serious than melanoma, but still some keratinocytic skin cancers or skin benign lesions. And this is due to a paradoxical activation of the MAP kinase pathway by BRAF inhibitor. And when you addition a MEK inhibitor, then you decrease this activation and you see almost none of these tumors on the skin.
So it's a kind of negative synergy in terms of toxicity. You're protecting.
Exactly, exactly. That's
now,
very interesting.
If you were to put months and years on it, what broadly were the figures in terms of progression-free survival and overall survival, which you have got a signal on, haven't you?
We have a very strong signal. We have a signal in overall survival. As I said, we don't yet have the median overall survival of the combination because it's not reached after a median follow-up of 11 months, so we'll see later. We have an increase of the progression-free survival. In median, it goes from 7.3 months with vemurafenib to 11.4 months with the combination, and the hazard ratio, which is actually the most important thing to remember. The hazard ratio is showing that there is a decrease of the risk of progression or death of 44%. And in terms of response rate, it's also very much increased. We have 64% of overall response rate with 13% of complete response with the combination versus 51% of response rate with the vemurafenib and 8% of complete response.
Right, so what is the clear message for cancer doctors?
The clear message is that the combination of BRAF plus MEK inhibitor, Dabrafenib plus trametinib, is more effective than BRAF inhibitor, vemurafenib only. And what is really very strong is that it's not the first trial to demonstrate that. We have a randomized phase 2 trial. We have another phase 3 that was comparing with Dabrafenib. We have this phase 3. And we also have the results from the Roche study with although a combination of anti-BRAF plus anti-MEK, and all these trials go in the same direction. So I really think that the combination will become the drugs to use instead of anti-BRAF only in this population of patients.
Okay, and in 15 or 20 seconds, the take-home bottom line, bearing in mind the other new therapies in melanoma too.
So we live an incredible time with melanoma. We now have a combination anti-BRAF plus anti-MEK that is stronger than the already very effective anti-BRAF treatment. And on the other side, we have immunotherapy with anti-PD-1 monoclonal antibody that are really stronger than ipilimumab that was already effective. So it's very good for our patients.